It is my great honor to introduce someone who, from our department, needs no introduction, but certainly deserves one, Dr. Appy Singh. She's a gastroenterologist and professor of medicine here at the University of California, San Francisco. She's the director of our GI cancer prevention program in the UCSF Lynch Syndrome Center. She's also the director of quality and safety for the GI division at UCSF. And personally, I can attest to some really rigorous and exciting discussions we've had as fellows about QI under her leadership. She's completed residency in internal medicine at Cleveland Clinic, followed by a fellowship in gastroenterology here at UCSF. She also has a Master of Public Health degree from Johns Hopkins Bloomberg School of Public Health, where she also received the Goodman Award. Passionate about medical education, she has served as the director of GI medicine clerkships and received an award for teaching excellence from the UCSF Haley Debat Academy of Medical Educators. She's the director of the UCSF Gastroenterology Grand Rounds, and she has led several leadership positions in professional associations, including vice president and president of the Northern California Society for Clinical Gastroenterology and executive council member of the CGA-IGC. Her research interests include medical education, improving identification and genetic testing for patients with Lynch syndrome, and other high-risk family histories. It's been an honor to train with Dr. Singh through my training here at UCSF, and I'm excited to see what we can learn today. Thanks so much.
Thank you so much, Molly, for such a kind introduction. I am very honored to talk to you all about future of cancer prevention, and we'll talk about Lynch syndrome vaccine trial. So let's get started. Here are my disclosures, not much relevant to today's talk. So my objectives in next 45 minutes include, we'll give you a brief overview of Lynch syndrome. We'll talk about current landscape of cancer prevention vaccine trials. And then we will talk about ongoing Lynch cancer prevention vaccine trials. Specifically, I'll discuss NEWS 209 and TRIAD-5 vaccine trials. So I love talking about this slide and this question, always a reminder for us to think. So what do you think is the population prevalence of Lynch syndrome in general population? Is it 1 in 10,000, 1 in 5,000, 1 in 1,000, or 1 in 300? Just take a moment, think for yourself. And as many of you have, we have discussed by now, it's actually very common. We have seen in population-based studies, it's about 1 in 300. The data we see is about 1 in 200 patients in general population have Lynch. We have seen that based on some European data as well. They found a very similar prevalence in Europe as well. And for other parts of this world, we don't have good data, but in general, we feel that worldwide prevalence is about 1 in 300 range. So irrespective of what subspecialty you practice, you likely have encountered patients with Lynch, but the sad truth is many of them, it's estimated that more than 90% of those are not aware of their diagnosis. So I love history, a little bit of background. Lynch syndrome is actually not a new condition. It was first recognized by Dr. Wharton in 1913, more than 100 years ago. He was actually a pathologist in Michigan. And here, his seamstress collected some family histories, and they found that there was a family, they called it family G. They had multiple uterine, gastric, colonic cancers. And they created pedigree at that time. And this is, we are talking long before we knew about genes or DNAs or genes. And this is the first family here. You see the black and white photograph of family G, which is known as the first known Lynch family. And when they studied 3 generations of that family, there were about 70 individuals, and 33 of those had various cancers. So very fascinating history. Later on, in 1985, Dr. Henry Lynch, you can see the colored photograph here, he coined the term HNPCCC, which is hereditary non-polyposis colorectal cancer. That was in 1985. I also love his historic background that he had many interests. Other than coining Lynch, he was a gunner in Navy, and he also was a professional boxer with his nickname Hammering Hank. So unfortunately, Dr. Lynch passed away recently, but a remarkable legacy. So we have talked about Lynch. Just a brief overview that it's a most common hereditary cancer syndrome. More than 90% are undiagnosed, as we discussed. So we now, with expanding cancer, genetic testing, we are finding many and many of these patients, but majority are still undiagnosed. 1.2 million individuals in this country are estimated to have Lynch. And as we know, about 2 to 3% of all colorectal cancer cases are due to Lynch. If you look at the younger cohort, so patients who are less than 50-year-olds, and you see how many of those have Lynch, about one-fourth, so about 25% of younger colorectal cancers are due to Lynch. And mutations in mismatch repair genes is the cause for Lynch syndrome. And all of these tumors are MSI high, meaning that those are microsatellite unstable. So Lynch syndrome is caused by 5 different mismatch repair genes. So any Lynch individual, they are all unique depending on their genotype. So, and their risk factors of their risk estimates will vary. So the genes are MLH1, MSH2, and I put EpCAM here because MSH2 and EpCAM, they behave very parallel. So their risks are pretty much the same, and they are clinically managed just the same. MSH6 and PMS2 are the other genes. So MSH6 and PMS2 are low penetrance genes. So if you look at the risk of colorectal cancer by age 80 for various genotypes, for MLH1 is 40 to 60%, MSH2 is 30 to 50%, and it goes down quite a bit for MSH6 and PMS2. For PMS2, the risk is 8 to 20%. And when you look at these numbers, compare that with 4% roughly average risk of colorectal cancer in average population. So when I counsel these patients, it's important to share the risk estimates because depending on which website my patient is reading, a PMS2 with no family history at all and incidental finding needs appropriate counseling because they shouldn't feel that they have, as high risk as MLH1 and they need every year colonoscopy, very aggressive. So the counseling has to be appropriate based on their family history, genotype, and other personal risk factors. In the past, when we did not test, we did genetic testing in high-risk patients only. So these risk estimates, if you look at older literature, will be a lot higher. At some point, we thought MLH1 risk is up to 80% for colorectal cancer, but with newer data, we have found the risk to be lower as we are testing more and more general population. So age to start colorectal cancer surveillance in these individuals for MLH1, MSH2, EpCAM is 20 to 25 years. Unless they have a young age colon cancer, then we start 2 to 5 years before the youngest age of diagnosis. In hundreds of patients I've seen, I have 2 individuals who had colon cancer at age 18, 19. Other than that, it's a little bit later. So we don't scope teenagers or kids, except those rare scenarios. Same for MSH6 and PMS2. Age to start colorectal cancer surveillance is 30 to 35. And this is a new change in last couple of years. In the past, we put them all together. Now the guidelines are becoming a little bit more gene specific. And my estimate is in future, we'll see these surveillance guidelines to get more precise based on various other risk factors. But for now, we suggest frequency of colonoscopy to be every 1 to 2 years for MLH1, MSH2, EPCAM, and for MSH6 and PMS2, 1 to 3 years range. So risk of various cancers in Lynch syndrome. This is just, it's a little hard to read slide, but I'm just giving you a reference to NCCN, which is a wonderful resource for these syndromes and their risk. And just to show you that, again, it's really important to counsel a patient, individualized risk factors. These patients have increased risk of various cancers. We talked about colorectal cancer, the other one, endometrial. So these are top two, colorectal, endometrial for all genotype. The other organs affected are ovarian, renal, pelvis, or ureter cancer. So I have a bunch of bladder cancer patients with Lynch, gastric cancer, small bowel cancer, rare, but you definitely see that in Lynch individuals. Pancreas cancer, biliary tract, so cholangiocarcinoma is also one of the Lynch cancers. And we are seeing some increasing data of prostate cancer falling in the Lynch spectrum, and some rare cases of brain tumor as well. Breast cancer, I'll briefly mention. The data goes up and down. It's variable. In general, the way I counsel my patient is, as of now, we do not think breast cancer is a Lynch-related tumor. Interestingly, many of the Lynch patients are found when they undergo genetic testing for their breast cancer, because in general population, breast cancer is very common, 10%, 8 to 10% lifetime risk, right? So when they may not find a breast gene, but they may find a PMS2 Lynch. So I have seen many, many patients who were found to have Lynch because of this pathway. So when counseling these patients, again, the risk estimates here, I always compare that to the general population risk and how their risk compares to that. And I'm not going to read through the numbers here, but counseling organ appropriate is important. For example, the bladder cancer risk is tiny bit elevated for this MLH1 genotype in this example. So important to counsel that patients are not canceling colonoscopy and just focusing on that bladder cancer screening. So the risks are variable. So I hope I showed you that these individuals have significantly increased risk of various cancer, and there is a high burden of testing on these patients, and their quality of life is significantly impacted. These are young folks. They have families, children, jobs, and them to fit in all of these testing is a huge burden. They undergo, many colonoscopies, endometrial biopsies, hysterectomies, oophorectomies, and even though they survive one colon cancer, they have a high significant risk of metachronous, a second colon cancer later in life. I recently saw a patient. He had his third colon cancer. So every 10 years, a colon cancer, and was on his third one. So they never really are, the risk is persistent. And then even if you do the most meticulous, perfect colonoscopies, they may still get into cancer because what we are learning is some of these Lynch tumors are not, they are not through the polyp pathway. So there was never really a polyp. What they have is ACF, abnormal crypt foci. So these are abnormal crypt foci, those little tubules our pathologists show us, and those are mismatch repair deficient, and they just start as a cancer. So there is no really a precancerous polyp phase for you to intervene. So how can we help these individuals, other than the screening, colonoscopies, is I hope I made a case that there is an urgent need for cancer prevention strategies like vaccine. So now let's move to the second part is cancer prevention vaccines. So, vaccines against virus-related cancers already exist, and you all know about HPV vaccine for cervical cancer prevention, Hep B vaccine for liver cancer prevention, and some other vaccines like EBV-related cancer, HTLV-1 related cancers. The vaccines are in pipeline. We may have them in very near future. So, what about vaccines against non-viral cancers? Colon cancer vaccine, breast cancer vaccine, ovarian cancer vaccine. So, could there be a day, you get a flu shot and at the same time you get a colon cancer shot? You get a breast cancer shot, in your vaccination healthcare maintenance. We may get there, but when, I don't know. I wish it's sooner than we want to, but it's sooner than it is right now. But a lot of research going on in exploring those pathways. So a little bit of my history interest. Who is this person? Why is this person's picture here? Um, this is Edward Jenner, who first smallpox vaccine, as you know, in 1796. So just to take you back, how long ago we started the vaccination journey, uh, uh, but we are not there for cancer prevention vaccines yet. So what's the current landscape of cancer prevention vaccine? So this is not something happening now. Pretty much in last decade, multiple trials have explored various cancer prevention vaccine. And then most of the vaccines that exist for cancer prevention right now, well, I shouldn't say cancer prevention, is like cancer, risk reduction, are actually in individuals who already have a cancer. So it's part of their therapy. So having vaccine to reduce the risk of recurrence or slow down the growth. Um, Vaccines in healthy individuals who never had a cancer, we haven't had much luck. And so it's challenging. Many of these trials have failed because identifying the tumor antigen that will be a target for the vaccination is challenging because they are actually a variation of the self protein, right? And this is a pre-existing protein, so creating, activating your immune system against those cancer cells, and could that activate autoimmune complications. And then other challenges we have run into is other than finding the right target for the vaccination is safety and what's the effective vector to administer the vaccine. So these are the challenges we have identified in previous vaccine trials. A little bit I want to show you this slide that Lynch related tumors we have known are immune mediated. So these cancers are part of the immune pathway. Uh, our pathologists, you may have seen in pathology lessons that Lynch related cancers, when they see on pathology, there is excessive tumor infiltrating lymphocytes to the point that these are known as Crohn's like some reaction in the cancer. So it means that your body itself is identifying these antigens as foreign and trying to fight it through your immune system activation. So there is some theory, we don't know, that in Lynch individuals, do they make microtumors that their immunity just takes care of it? Because if you do immune analysis of these individuals who never had a vaccine, they already carry some immune activity, some T cell markers, some antibodies that are against tumor cells. So there is some autoimmune immune mediated pathway already going on in these patients. So the theory was to utilize that pathway and like enhance and boost your immune system to fight the cancer So have we seen any vaccine trial outside Lynch in colon cancer so this was an interesting study we saw in 2023. It was a vaccine trial for colon adenoma prevention. So these are not individuals with Lynch. These are folks who are sporadic advanced adenoma. It was a double-blind randomized controlled trial at 6 centers across this country. And then they had 103 participants with newly diagnosed sporadic advanced adenoma. And they were given MUC1 peptide vaccine, and they were given an agonist adjuvant to enhance your immunity against this antigen immune cell activation was TLR3. And they gave half the patients placebo. And their primary endpoint was adenoma recurrence at colonoscopy 1 year from initial vaccination. So what they found that adenoma recurrence rate was not reduced in intention to treat analysis. But when they looked at just a smaller cohort for the small number of patients who were immunogenic to the vaccine, so you can study their immunogenicity by assessing the immune markers. So they found that the vaccine was immunogenic only in 25%. So just a 1/4 of these 100 patients or those who received vaccine were immunogenic. And then if you just look at those patients whose body could activate the immune system, they did find that there was a reduction in adenoma recurrence rate in those immunogenic individuals. So if your body can make and activate your immunity, your immune cells, it does reduce. And they also found that the vaccine was very well tolerated. The reactions were grade 1 to 2, which is mild reactions. So other cancers prevention, what vaccines, and I'm talking about healthy individuals. So this vaccine got some media attention. It's ovarian vax, which is an ovarian cancer prevention vaccine. This is underway at Oxford, and they are looking at BRCA1 and 2 carriers. Can they train the vaccine with the vaccine to train the immune system to recognize and eliminate cells prone to developing into ovarian cancer? So the goal is to give healthy BRCA1 and 2 carriers a vaccine and to see if that will lower their risk of ovarian cancer. So the trial is recruiting, and we look forward to seeing the results. All right. And we talked a little bit that various vaccine cancer prevention trials have failed. The right antigen, it's hard to identify too many tumor antigens. And then even if you use that for vaccination, our immune response to those is variable. Very small fraction of patients activate their immunity against those antigens. And the other reasons we have seen for failure are that many of these trials have been done on patients who already have a cancer. So you could argue that, advanced existing tumor is immune suppressive. So that's why they don't activate their immunity to those cancer prevention vaccine. And those patients are on chemo and all other reasons they are very immune compromised. So should we study the cancer prevention vaccines in healthy individuals who have robustly functioning immunity to see whether it works? So on the same line, like how else can we activate your immune cell, your body's immunity to respond to the vaccines is through give some immune enhancers to boost immunogenicity. So various agents have been tried. Examples are, we talked about TLR3 agonist. It had limited potency, wasn't that strong. Then IL-2, IL-12, they did work, but they were too toxic, too many side effects. And using a cancer prevention vaccine in healthy individual, which has a high side effect, is not going to go far. So then IL-15, also known as N803, is promising. It has been found to be safe and effective. This has been used to improve the efficacy of the vaccines, and has been used in more than 600 plus participants in 25 completed and ongoing studies. So plenty of good data for this to be safe and effective. So some promising news on that end. So a little bit, I also want to talk about frame shift peptides before we dive into the Lynch vaccine trials, because one is based on frame shift peptides. So what is frame shift peptide in Lynch syndrome? So as we know, in Lynch individuals, there is mismatch repair deficiency. So in all of their cells, one gene that repairs the mismatch of ATCG. If they're mismatching, the repair mechanism is missing in every single cell, right? If they have Lynch. So but the cancer formation happens when there is a second hit in the second gene, which was functioning but gets second hit for various reasons in their lifetime, and then both the alleles are non-functioning, and their mismatch repair mechanism will fall apart in that particular organ. And many of these mutations are indel, which is insertion and deletions in, and that the repair will not happen given the dysfunction of the mismatch repair system after the second hit. So this leads to formation of frame shift peptides. So the whole code, if you insert, let's say, in a sequence, you insert an extra A or extra T, there will be a frame shift mutation. The whole spelling, imagine, of a letter. If you insert a letter in a word, everything will, the meaning will change. And this frame shift leads to frame shift peptide formation, and these are called neoantigens. And this is what is being used as a target in NOOS 209 vaccine trial, which we will talk about. But before we go into the phases of trials, just a little reminder that clinical trials, phase 1 trial focuses on safety and the proper dosing done on a small number of patients. And the vaccine trials we are talking about are phase 2, which is focused on effectiveness and side effect. And phase 3 and 4 are later stages when in phase 3, we compare the new treatment to the existing treatment. It's done on hundreds of individuals, and phase 4 is post-launch. So let's talk about the first Lynch cancer prevention vaccine trial, which is NOOS 209 phase 1b/2 trial. It's a single-arm, open-label clinical trials of NOOS 209 monotherapy. It's going on at 4 centers: MD Anderson, Fox Chase, City of Hope, and University of Puerto Rico. And they are giving intramuscular injections of this vaccine on day 1 and a repeat at week 8. Eduardo Villar Sanchez is the PI from MD Anderson for this trial, and they have enrolled 32 individuals, and they have found that in these 32, they presented their interim analysis. No treatment-related serious adverse events were noted. So as of now, we have data of the safety. The efficacy will take a couple of years for us to learn about, but promising data on the safety. And then they also collected blood samples and studied the immunogenicity. Are these individuals activating the immune system? And interestingly, they found that 100% of evaluable participants, they they had good immune activation, and they had vaccine-induced T cell response was seen in 23 out of 23 individuals. So that's promising as well. So we'll find out. As of now, this is the data we know about the NOS 209 trial. And then I just discussed with the PIs, so they are not recruiting new patients of this phase of the trial, but they will follow these individuals in long term, and we'll see. So that was first trial for Lynch cancer prevention. And now let's talk about the second trial, which at UCSF we are part of, which is a Tri-Ad5 vaccine trial. There are multiple centers across the country participating, and the list is growing. I have listed some here. So this is a Tri-Ad5 Lynch vaccine trial. It's an NCI-sponsored trial. It's a phase 2B, double-blind, placebo-controlled trial. So half the individuals are designed to receive the vaccine, and half will receive placebo. So just a saline. And patients often reach out to me asking, can you guarantee that I get the vaccine? And unfortunately, the short answer is no. It's a double-blinded. So both PI, I am blinded, my research coordinator is blinded. It's just a pharmacist who knows which agent is being administered. And there randomization happens at the central place when we provide the patient information. And the vaccines, syringes we receive, they are just labeled as study agent. So we don't do it, we are blinded and cannot choose. So it's in the vaccine, what does it contain? So it has 3 tumor-associated antigens. So the PIs for this trial from the PIs are Dr. Bansal from Kansas and Dr. Eduardo Villar from MD Anderson, co-PIs. And for this trial, they included 3 tumor-associated antigens based on the prior data, which are expressed in pre-malignant and malignant lesions, so colon cancer, adenomas, colon cancers, colon adenomas have high level of expression of these. So CEA, MUC1, and brachyury. And these are not just specific to colon, because these have been found to be expressed in non-colonic tumors as well. So that even though the trial is looking at colon cancer risk reduction, we are hoping that we'll see if we see reduction in other non-colonic cancers as well. So one part of the vaccine is the 3 tumor antigens. And as we discussed, we have learned that we need an immune enhancer. And for this trial, they are using IL-15 superagonist, which is N803. And then, so there's a tumor antigen, there's an immune enhancer, but you need a vector to administer and create the vaccine. And for that is the vector is adenovirus 5, recombinant modified adenovirus 5. So adenovirus 5, this vector is made replication deficient, like standard vaccine vector pathophysiology by deletion of early E1 and early E2B gene regions of the virus. And this deletion results in the virus is made replication deficient, and that also made it reduced immunological clearance. The body, is not trying to clear it off after the modifications. And this has been studied in other trials. It has excellent safety profile. So just a clinical experience so far with recombinant Ad5 based vaccines. These have all been done in patients with various cancers. I wouldn't go into the details for this talk of these individual trials, but this vector has been used in patients with metastatic colon cancer, already existent cancer, various other prostate cancers, and they found that it was safe in those trials. So now moving on to IL-15 super agonist, which we discussed a little bit, it's an immune enhancer and it robustly stimulates NK cells and CD8 T cells and effector memory T cells. Enhancing your response to the three tumor antigens and activate your both T cells, cell-mediated, antibody-mediated immunity for the vaccines. So for this trial, what is the primary endpoint? So mainly the trial is going to look at cumulative incidence of colorectal neoplasm, so adenoma and cancers, on 2 follow-up colonoscopies over 2 years between vaccine plus adjuvant. So I'll call it together as vaccine versus placebo. So patients will be followed up for 2 years. So that's the main primary endpoint, but this trial has various secondary and then exploratory endpoints. A few highlights I have added here are, of course, we'll study the safety and tolerability, and patients are allowed to take aspirin and NSAIDs. We just collect a lot of data, and we'll try to see how that impacted response to the vaccine, and smoking, alcohol, the standard will be looked at. And we'll look at incidence of extracolonic cancers as well. And you may argue that is 2 years long enough for cancers and adenoma risk reduction. For various logistics reasons, the study is designed for that period for now. So that's why UCSF will lead a second exploratory arm, which will be effect of vaccine on abnormal crypt foci. So can we look at patients with Lynch? What's their abnormal crypt foci at the baseline, and what happens at follow-up 1 year and 2 year colonoscopy? Does the number of abnormal crypt foci go down with the vaccine, which is an evolving theory of precursors of cancer formation in patients with Lynch? So we will find out. This is the study schema. So there was a safety phase first, which is already completed to make sure the vaccine is safe on 10 individuals. Then the phase 2 was patients were given both the vaccine and the immune enhancer together, again in 10 and overall safe. And at present, this trial is in this big box of randomized controlled trial. And the goal is to recruit across the country about 140 individuals, and half will get roughly vaccine and half will get placebo. So here is a set schedule of events. So patients get a baseline colonoscopy, and then they get the vaccine at week 0, week 4, and week 8. And then that's the first series of 3 sets of vaccination. And then they get a booster at their week 52 follow-up. And that's the time they get a colonoscopy, which is a 1-year colonoscopy. And then the vaccination ends at that point, but they do come for a second follow-up colonoscopy at 2 years to look for their colorectal neoplasia. Inclusion criteria. So patients with Lynch for non-PMS2 genotype, they must have had a prior history of adenoma or colorectal cancer. So if you have a patient with Lynch, they never had an adenoma of any kind or colorectal cancer, they will not meet criteria for inclusion in this trial. For low penetrance gene PMS2, they only include PMS2 patients who had a prior colorectal cancer and now they are 6 months colorectal cancer free. So these low penetrance one have a different inclusion criteria. Exclusion, so many are obvious, active malignant, they have to be cancer free or free of any cancer directed therapy in last 6 months. And then, they shouldn't have organ transplant, HIV, Hep B, Hep C, AFib, or past severe reaction to other adenovirus-based vaccines like Johnson & Johnson COVID vaccine, which is based on the similar vector. So that's an inclusion. So anything that will impair their ability to activate their immunity is excluded. And pregnancy or planning to be pregnant is an exclusion as well, because we don't know the safety in those cohorts. So here, vaccination, patients receive 4 injections. So when they're ready, when they come here, so we said that these are, 3 vaccines, MUC1, brachyury, CEA. So they come in 3 different syringes. They get those in their thigh. So 3 alternating thighs, 3, so 2 in one thigh, 1 in other. And then the 4th one is the immune enhancer, which comes in a different syringe on their own, and that's given in their abdomen. So these patients get 4 shots when they come, and then we will give them a booster at 1 year. So common side effects of the vaccine, yeah, they are listed here, but the vaccine itself in general is safe, but the immune enhancer, it's supposed to activate your immunity, so it will cause local reaction as well. They get some skin reactions, that's quite a bit. Many patients they go home and they have some flu-like symptoms, but we have noticed some redness, induration in the abdomen where the immune enhancer is given. But fortunately, none of the individuals had severe reaction. So that was promising. We discussed the side effects already, so key takeaways today. I hope I was able to convey that Lynch syndrome is common, but most are still undiagnosed. And Lynch-related tumors are immunogenic, so your immunity plays a significant role in formation and clearance of these tumors. And multiple neoantigens and tumor-associated antigen-related vaccine trials are ongoing. And early results, what we know so far, that these vaccines are safe and immunogenic. Are they effective? We will find out, in the coming years. These targets are involved in several other cancers. So even though the trials are for colorectal cancer prevention, we'll have to see if that will result in multi-organ cancer prevention as well. So I want to just end the talk with my acknowledgements and thanking UCSF Lynch Syndrome Center. This takes a village, and I have a huge village. These are my key collaborators. Couldn't do this work without their help. And here, you see a little Bernie in the bottom. It's not my colleague, but it's something we are proud of as part of UCSF center's mission to coordinate care for these individuals. We have a specialized gurney in endoscopy that you can do procedures as usual, but it does have stirrups that come up, and we are able to do endometrial biopsy for these patients at the same time when they wake up from their procedure, because women with Lynch, individuals with uterus, they undergo endometrial biopsy every 1 to 2 years until they get hysterectomy. And endometrial biopsy outside endoscopy setting is done by gynecologists awake. And it can be a very discomforting, unpleasant procedure. So by combining it with sedation, we have found patients to be very appreciative, other than, of course, improving the logistics of multiple visits and financial parking, all those things. And on this, just going back on the center, you will see a tab that says Hereditary Cancer Risk Calculator up top here. If you go there, this will take you to our UCSF Hereditary Cancer Risk Calculator. So this can be used by, it's designed for a patient, so it can be used by anyone. So if you have a patient, they say, this aunt had this colon cancer, this uncle had this pancreas cancer, should I get genetic testing done? So this calculator is designed for 2 most common. We included not just Lynch, also BRCA, because it's equally common in general population. So we used NCCN criteria for colorectal cancer, for Lynch and BRCA testing, and we put them together in this logic-based calculator. So it just takes you, it's very intuitive. We have tested on patients already. It's already live and functional. So they can enter their family history. It takes you one by one. And in the end, the output is you meet NCCN criteria for Lynch BRCA testing. And then we do not collect any patient information. However, in the bottom, if they say, if I meet criteria, I would like to see a UCSF genetics team, patients can enter their contact information, and that output is automatically in back end sent to UCSF contact center, and they reach out to patient. They get insurance information, do the scheduling, all of those. For patients who are outside California or cannot be seen at UCSF or don't want to be seen, we do give them a link for genetic counselors resources across the country, and they can reach out to them to get tested. This workflow is live, and we have already had various patients not just contacted by contact center, made appointment and undergone genetic testing. So we look forward to seeing how this impacts overall our efforts for improving detection and care of patients who are high risk for these cancers. With that, I truly appreciate your time and attention, and I will be more than happy to answer any questions. Thank you. I wasn't looking at the chat box, so let me see.
That's perfect.